Dr. Shah is known for his patient-centered approach to medicine and believes every patient should have an individualized treatment plan. His focus is to improve patient quality of life using the newest advances in medicine and surgical technology. Dr. Shah enjoys traveling and spending time with his friends and family. With that, let's welcome Dr. Bhavik Shah.
Thank you. I appreciate the introduction, and I appreciate everyone having me here today. Most importantly, I appreciate any male that actually showed up to this talk, because men are infamous at not showing up when it comes to their own health. So today's topic is prostate and really men's health in general. The goal is to really advocate for men and encourage them to seek out help if they need it. So we'll talk about a couple things. One, I'll talk a little bit about, I'll explain what urologists do. I want you to understand prostate cancer screening. And then we'll talk about some other general urologic diseases that sort of pertain to men's health in general. So a little bit about me. So a lot of people ask is, hey, why did you, of all things, why did you get into men's health? And so just in order to understand that, you kind of have to know a little bit about my background. I was born in India. I was there for a very short amount of time. And then I actually grew up in Africa. And so in Africa, I kind of traveled around Zambia, Zimbabwe, Botswana, the majority of the time South Africa. So kind of all over the place. And then I eventually, around age 10, migrated to Chicago. That's where my sister was born. I lived there for a year. Then I ended up in Tampa, grew up there for a long time. My family, in fact, my parents are still down there. I ended up going to the University of Florida, the best football program in the nation. And then over there, I did my undergrad. I went over to Ohio, did my med school. I met my beautiful wife there. Came back to Tampa, did my training there at one of the top men's health centers in the world, really. Had my daughter there. And then I ended up in Atlanta, and that's where I am now, with my first job out. And now we have a beautiful son. So everyone always asks, well, okay, but how does this explain anything? Well, I mean, what I tell everyone is my path was kind of mapped out on its own, and that's what kind of got me into penile implants and men's health. So all of that being said, let's talk about what urologists do. Just basic anatomy. You have and this thing is kind of blocking. Let me see if I can move it. So you have your kidneys, your bladder, your ureter. Your kidneys are this bean-shaped organ right here. They're what kind of get rid of toxins, waste. They get rid of medications. So medications are filtered through there. So that's one way to release your waste. The other one would be your liver. The ureters are these tubes that drain the kidneys into the bladder. The bladder is the storage pouch that holds the urine. And then you pee it out, you pee everything out through the urethra. So the urethra is the channel that empties the bladder. And then the prostate is this opening. I'm not sure if you can see the, you can't see my mouse moving, can you?
Yes, we can.
Oh, you can, okay. So it's this area down here that drains the bladder. And that's one I'm going to talk about. It does have some uses. It surrounds the opening, so that's a negative use. It can as it grows, it can sort of compress on this opening. And when it compresses on this opening, it can actually find a way to make this little box go away. Okay, there we go. So, and as it compresses this opening, it can actually, it's more difficult to empty your bladder. So that's a negative thing about the prostate. It does have some positives. It helps secrete fluids and your ejaculate. So when you ejaculate, that's where it comes from. And so your ejaculatory ducts attach to the prostate. So there is some value there. When you're in puberty, it's what helps you develop some of your secondary male characteristics. In men, women don't have a prostate, but in men. And then after puberty, the value is significantly less. Some other basic anatomy, you have your genitalia, the penis, the testes. The penis is obviously your male reproductive, your primary male reproductive organ. And then your testes make testosterone and they make sperm. And testosterone is important for a lot of things, including heart health, bone health, your sex drive, your energy, your sperm, your fat metabolism, and things like that. So let's start with the prostate. You know, it is prostate awareness or prostate cancer awareness month. And so it is important we talk about this. And so everything kind of starts with PSA screening. And I'll tell you, there's a lot of controversy with PSA screening. And so, you know, those are some of the things we're going to talk about. We're going to talk about all the guidelines and what they say. And hopefully by the end of this, you'll either be thoroughly confused or you'll have a much better understanding of prostate cancer. Prostate cancer, why does it matter? Because it's the second leading cause of cancer death in American men. And that's just behind lung cancer. That means 1 in 41 men will die from prostate cancer. So prostate cancer is a serious disease, but the vast majority of men that have prostate cancer will not die from it. In fact, more than 2.9 million men in the United States have prostate cancer or are diagnosed with prostate cancer and are still alive today. So what does that mean? Well, most cancers are low risk or indolent, and that means that they are very, very slow growing when it comes to prostate cancers, and they're most likely not going to harm you. Knowing that you have them, so knowing that you have this prostate cancer, that can trigger invasive testing and anxiety, and oftentimes that anxiety will lead to men opting for invasive treatments that can impede or hurt your quality of life. So part of the problem is over testing. PSA, which is the prostate cancer screening test, it's a blood test, is an imperfect test. It's specific to the prostate, but not necessarily specific for prostate cancer. And so that's where all the controversy is. Should you do PSA testing? Should you not? And that's where the controversy lies. So the current guidelines for PSA, the USPSTF guideline, it states that men who are 55 to 69 should at least discuss PSA testing. So they should undergo shared decision making and make a decision on their own on whether they want to do PSA testing. They recommend men 70 and older not get PSA testing. Now, this is important. They do not make separate recommendations for high-risk individuals. And when I say high-risk individuals, we're going to talk a lot about high-risk. High-risk individuals are African-American men and men with a family history of prostate cancer. Okay, and that's important because African-American men are at higher risk, significantly higher risk of not just prostate cancer, but more aggressive prostate cancer at an earlier prostate cancer that likely will harm them in their lifetime. And these guidelines, these are the primary guidelines that most primary care physicians do not address that or even discuss that. The NCCN guidelines, which are the most common cancer-related guidelines, have similar recommendations, but they don't tell you a category of patients that should not get treated. They recommend testing somewhere between 45 and 75. And they say for men over the age of 75, you can start slowing down who you would biopsy. The AUA guidelines, these are the guidelines that the vast majority of urologists will use. They recommend against screening men under the age of 40. They reserve screening of men between the age of 40 and 54 to just high-risk individuals. So men with a family history of prostate cancer or something related to the prostate like breast, ovarian, or pancreatic cancer, and African-American men. And then they stated in the data, the greatest benefit to screening is men 55 to 69 years old, which guidelines will agree with. And then when it comes to older individuals, they recommend considering either slowing screening or stopping screening, especially if the PSA is very, very low. Because if the PSA is very, very low and low is under 3, the likelihood of getting prostate cancer that's going to actually harm you in your lifetime is very low. And when I say very low, I mean well under 1%. So for men with a PSA under 3 over the age of 70, there's not much benefit to screening. Now, there are men that are 70 and older that are very healthy and probably going to live another 40 years. And those men are a little bit of a different category. And for those men, it is reasonable to continue screening. But these are some things to think about. The ACS guideline is another guideline that a lot of surgeons use, and they recommend prostate biopsy or continuing PSA testing if your PSA is 2.5 or greater. And that's yearly testing. And men with a PSA under 2.5, they recommend extending it to every other year or further. And again, they recommend starting screening at age 50 and starting high-risk screening at age 45. So what does all this mean? It gets really confusing. I just threw a bunch of guidelines at you, and that really confuses the heck out of everyone. So here's a simplified version. If you are high risk, and high risk means African American, or you have a family history, a first-degree relative, your father, your brother, that have prostate cancer, or a sister or a mother that has breast cancer or ovarian cancer, especially if they were diagnosed at an early age, you want to start screening somewhere between 40 and 45. That's what most of the guidelines will state. If you are your general risk group, so a non-African American with no family history of those cancers I mentioned, then you want to start screening. You want to consider starting a screen between 50 and 55. Decision making is important. So you should talk to your primary care doctor or urologist about whether you really need to screen, what your interests are. If you were found to have prostate cancer, would you? Things like that. Those are important conversations to have. If you say, look, I'm 65 or 70, even if I have prostate cancer, I'm probably never going to treat it. I'm not going to do radiation. I'm not going to do surgery. In that case, you probably don't need to screen it, because all you're going to do is add anxiety to yourself, undergo invasive testing like a biopsy with no benefit. Men who have less than 10-year life expectancy should stop screening. So if you have severe COPD and multiple heart attacks, and chances are you're probably not going to live, you're 95 years old, and you're probably not going to live 10 more years, you probably don't need to be screened. And then men who are over the age of 70 with a very low PSA probably don't need to be screened either. So those are conversations you should have with your primary care doctor. It is important to talk about prostate cancer screening because, again, prostate cancer is the #2 cause of death in men. Okay, so it is something that's important. Okay. So let's say you have prostate cancer, right? One of the problems with prostate cancer is the treatment, right? The treatments have side effects. The treatment side effects: leaking, going to the bathroom frequently, erectile dysfunction problems, things like that. So what are those problems in specifically? Urinary incontinence. After surgery, about 25% of men will have symptoms of urinary incontinence. In fact, immediately after surgery, 100% of men will have incontinence, and that means leaking. We cough, sneeze, stand up, walk, you leak. It gets better with time, and typically within a year, 90+% of men will have regained all of that back, and so they won't be leaking anymore. If you happen to fall in that 10% of men that are still having some degree of incontinence, you can see a urologist, and urologists, especially ones that specialize in things like prosthetics, including myself, can fix these things, including leaking. There are simple things like a sling or a sphincter. So there are surgeries that we can do to make it so you're not leaking anymore. And these are some of the cool things that we do. If you have radiation, one of the things that can happen is you can have very irritable symptoms. You feel like you're going to the bathroom all the time. If you have enlarged prostate with radiation, it worsens. And when you've had radiation and you have enlarged prostate, you don't want someone shaving open the prostate because it can make you leak all the time. One of the cool procedures we can do is put these little clips here. It takes about 5 minutes to do. It's called a urolift. Open up the prostate and make it so that you're not leaking anymore. I mean, you're not having enlarged prostate symptoms anymore because we've opened up the channel that you pee through. And so there are really cool, innovative, minor ways we can fix a lot of these symptoms. Erectile dysfunction. 44% of men will have erectile dysfunction after surgery. 23% will have erectile dysfunction right off the bat, or approximately at 2 years after radiation. So you can see a lot of patients will have erectile dysfunction. It is all treatable. There are lots of ways to recover it. And one of the ways is to do a aggressive penile rehabilitation program, which is what I put all my patients on that get that surgery or radiation. But let's say you fall into the percentage of men that need something more. Well, there's something called a penile pump or prosthetics that we can use to allow you to have an erection whenever you want. You can have sex for as long as you want, and you can bring the erection down whenever you want. And it's a minor 30-minute outpatient surgery. Radiation proctitis, you can have irritation of the bowel because the bowel sits right next to the bladder. And so when you give radiation to the bladder and the prostate, that can extend down to the rectum. You can have rectal pain, frequency, urgency, feeling like you're going to the bathroom all the time, your fecal leaking. So you can have all of those things. There are protective measures that a urologist can do before you get radiation to try to reduce that risk. We can inject Spacor, which is a spacer, a gel that self-dissolves after a period of time that'll separate the prostate from the rectum below and reduce the likelihood of you getting radiation proctitis. If you still have leaking after radiation, we can fix that too. There's a cool little battery that we can hide under your skin. And what it does is it stimulates and calms both the bladder and the rectum down. So it's not so hyperactive, and it'll reduce the leaking from both, again, a urinary standpoint and a bowel standpoint. So in summary, shared decision-making with PSA screening is important. Talk to your urologist or your physician about PSA screening because it's more important than you think, and especially if you're in that high risk category. And again, high risk is African American, okay? So an African American male or someone with a strong history of either prostate, breast, or ovarian cancer, okay? So if you have that family history, those are persons that should get evaluated, get their prostate evaluated, okay? And if you happen to be an African American male with breast cancer, yes, men can get breast cancer, then extremely high risk, and you should get very closely monitored, okay? And if you need treatment, don't be scared of it. I know a lot of men don't want to know if they have prostate cancer because they fear the treatment of prostate cancer. Nowadays, we do things robotically with very, very, very minor, minimally invasive ways. And if you fall into the small group of patients that have some of the side effects of surgery, including erectile dysfunction or leaking or anything like that, it's fixable. And that's where urologists like me that specialize in quality of life improvement are there to help you get through that, help you recover, and help you get your life back to normalcy, okay? But if you have prostate cancer and it kills you, I won't be able to help you, right? So if you already have prostate cancer and it's already spread, once prostate cancer has spread, there's no cure. At that point, we do the equivalent to cutting off your testicles, trying to eliminate all your testosterone in hopes that we're cutting off the food supply for the prostate cancer and slowing it down. So Treat it early. If it's in the prostate, it's curable. If it's outside the prostate, it's not. So a couple real life scenarios, okay? Let's say you're a 30-year-old African-American male. Your father had prostate cancer. You've never had a prior PSA. What should you do? These questions are a lot more fun when patients can answer. You're welcome to unmute yourself if you want to answer the question. I'm curious as to how many people are actually going to unmute themselves and answer, but I'll give you about 5 seconds to unmute yourself and answer it. Tell me what you think you should do, and then I'll give the answer.
I'm going to say C.
Okay, good. Good question. Yes, so you want to wait till you're 40, with the exception of patients whose father had prostate cancer at an extremely early age, like 30, which is very, very, very rare, right? So if you happen to have, typically, if your father had prostate cancer early, then around that age or 5 years after that age is when you're going to say at the latest you want to start screening. So if he happens to be 30, and I've only seen one 30-year-old in my life that had prostate cancer. So if he was diagnosed at an extremely early age, then usually within 5 years of that age, you want to consider prostate cancer screening. But you're right. The correct answer is wait till age 40. That's the earliest you really want to do screening in any other setting. Great job. Okay, I'm glad someone was listening. I appreciate that. Okay, scenario 2, you are a 50-year-old male. You're interested in routine PSA screening. You have a history of enlarged prostate, and you have urinary symptoms that include burning when you're peeing, frequency, waking up at night. These have been there for just a few days. Your urine test is worrisome for urinary tract infection. Your PSA last year was 2.6. And yesterday it came back at 35. What do you do next? Anyone want to chime in? Oh,
A.
what's that? Okay. Well, let me give the answer if no one else wants to answer. This is a hard question. Your PSA is scary. It's 35. But remember, PSA is specific for cancer. So anything that stresses your prostate, including if you just had sex, you just went bike riding, you just went motorcycle riding, you're pushing on your bicycle seat where the prostate sits, or if you have an infection in your bladder, right? All these things will stress and strain your prostate. And so if you stress and strain your prostate, the biggest culprit being a urinary tract infection, it can elevate your prostate, your PSA. So you should talk to your urologist, and he should likely put you on antibiotics. But you also don't want to do a biopsy in the setting of a urinary tract infection anyway. Make sure that urinary tract infection is treated, and then recheck a PSA in 3 to 6 months. If the PSA comes down dramatically back to 2 or 2.6, you may not need to be screened. If it doesn't, then you may need to be screened. Okay, 2.6 is still not super low for a young 50-year-old male, so it's still a little bit high. So you may still need screening, but you want to wait until you've treated that urinary tract infection and reevaluated the prostate generally. You're a 75-year-old Caucasian male, you have diabetes, you have COPD, you have heart disease, you had a heart attack yesterday, you have no family history of prostate cancer, you do have known enlarged prostate, you take Flomax, and your PSA check last week was 2.5. With respect to PSA screening, what should you do next? A, see a urologist for prostate biopsy. B, get a Urology rectal exam done. C, talk to your PCP and urologist about stopping further screening. D, stop your Flomax. Or E, get PSA screening less frequently, maybe every 2 to 3 years instead of yearly. Anyone want to chime in on this one?
I'm going to say E.
C.
Okay, good. Well, both good options. Remember, men over the age of 70 are less likely to benefit from screening, And men who are over the age of 70 with significant comorbidities, just had a heart attack, have diabetes, have COPD, on oxygen, and are expected to live less than 10 years or even 10 to 15 years, are almost not likely to benefit from PSA screening. And then men over 70 with a PSA less than 3 are extremely unlikely to benefit from PSA screening. So in this case, we have a Caucasian male, so he's low risk. He has a million, comorbidities, so he's not the healthiest person. So he has no family history, again, low risk, right? His PSA is less than 3, so again, very low risk, right? So for him, he's an extreme, and he's over the age of 70. So again, in that group where prostate cancer screening is unlikely to be beneficial. For him, to reduce the ambiguity, you have like 4 reasons to not do PSA screening. And so it's worth talking to, your primary care doctor about stopping screening altogether. And so this is, I'll tell you, most primary care doctors and even a lot of urologists are very reluctant to do that. But in this patient's best interest, it probably is a good idea to just stop testing, because what if you have a urinary tract infection, or you go bike riding and your PSA jumps to 15 for that day? Someone may reflexively say, hey, you need to get a biopsy, or you need to do something. And it's something that you may not want to do, because even if we find a prostate cancer, it's most likely going to be a low risk type that's not going to harm you. But if you find it, then we're going to follow you. You're going to get very frequent testing. It's going to end up hurting your quality of life for something that probably wouldn't harm you. Okay, so nice job with those answers. And yeah, you made a good point with question E. This was not an easy question, and I do appreciate you chiming in. So, okay, any questions about prostate cancer? Okay, so then I'll keep going. I'll fly through this. Stop me at any time. This is the rest of men's health. So testicular pain, if you have sudden acute testicular pain, I want you to know it can be a whole host of things. Like your testicle could have twisted, which means it's twisted on its blood supply, and you can lose your testicle if you don't get it treated in 6 hours. You could have epididymitis, which means an inflammation or infection of the testicle, and it can be extremely painful if you don't get it treated if you don't get it treated with antibiotics or an anti-inflammatory. You can have a cancer, and so you can have a cancer that presents just like the other ones, a testicular swelling, and that can obviously lead to other problems and spread. You can have worm-like appearance of your scrotum, and that's enlargement of veins. You can have fluid around the testicle, and when you shine a light to it, it lights up kind of like a light bulb. You can have a skin infection over here. You can have a testicular fracture, where if you got a car wreck or an injury, or you were bike riding and hit a tree and your testicle hit the tree, or you got kicked in the testicles because your wife was very upset with you. Any of that can cause a testicular fracture, and that can be a surgical emergency. It needs to be treated, or it can lead to infertility. So here's a quick example. You have an 11-year-old son with acute right testicular pain. It started 3 hours ago. He denies any injury. He was just horsing around at school and suddenly felt the pain. He rates it 9 out of 10. It's very severe. It hurts a lot. You get anywhere near, you look at it and it hurts. He refuses to let you touch it. He screams if you get near it. What should you do? Sorry, say that again. You're breaking up. Okay, any takers?
A.
Yes, take him immediately to the ER. And the thing you're worried about is testicular torsion, the twisting of the testicle. All right, that's an emergency. The clock is ticking. He has 6 hours to untwist it. If it is not twisted in 6 hours, there's a very high likelihood he loses his testicle. Example 2, you're a 68-year-old male. You have acute left testicular pain. It's severe, 9 out of 10. You notice it's been getting worse over the last week. It's swollen, it's hard. You have a history of an enlarged prostate, and you get frequent urinary tract infections. What do you do next? Go to the ER. schedule to see a urologist, call your primary care doctor, try to untwist your own testicles, stop being a baby.
Go to the ER.
You can go to the ER, and that's not the wrong answer, because you can see how hard it is to differentiate between this scenario and the previous scenario. They both sound very, very similar. In this setting, because you've had it over the course of a week, it's been well over 6 hours, either you've already lost your testicle, or more likely you have something called epididymitis, where you have an inflammation of the testicle. But you're right, the answer is always go to the ER. It's not, if you are very savvy at medical stuff, it's possible you just see a urologist and next week, and it's not unreasonable to call your primary care doctor, or at least see your primary care doctor and get antibiotics. But anytime you have severe testicular pain, 9 out of 10, just see a urologist, just to be safe. I'll also tell you, torsion is less likely in older individuals than younger individuals, but not unheard of. And don't try to untwist your own testicle.
I
Okay.
think was there a question from the prostate somebody had?
Yeah.
Okay, one thing that I would wanted to understand, is there a correlation between prostate cancer and diet?
Great question. So there is a little bit of a correlation, but it's very low. For the most part, obesity does increase the risk of prostate cancer. So being healthier and eating a healthy diet also can reduce your risk of prostate cancer, but it's a very low correlation. So for the most part, the data is not very strong to support, dietary changes and prostate cancer. Now, what most people ask me is, once they have prostate cancer, they say, hey, is there anything I can do diet-wise to reduce that prostate cancer growth? And that one is a no. There really isn't anything from that standpoint. Once you have prostate cancer, there's nothing that's going to make it go away food-wise. Any other questions? Okay, so I'll keep going. Again, stop me anytime. If you have any questions, you can put stuff in the chat group, and Ebony will keep an eye on that, and she'll stop me in the middle when it's a good time, and we can answer those as well. Okay, so difficulty voiding, having difficulty going to the bathroom. Let's say you're an older individual, 60, 70, 80, you're having trouble going to the bathroom, you're having urgency, your frequency, you wake up at night, you can only pee dribbles, you have to strain to empty, you also have diabetes, you have enlarged prostate, that your primary care doctor said your prostate was big. Let's see. What are the possible causes? Well, it could be your prostate, a blockage from your prostate. Rare causes could be prostate cancer. It could be scar tissue in your channel. The most common are a big prostate. You could just have a poorly functional bladder because of the diabetes. If your diabetes is not well controlled, that's a common cause of your bladder being irritated. The sugars in the bladder from poorly controlled diabetes could be irritating. What was that? Ebony, I think you're unmuted, and so I keep hearing you talk. Unless you were chiming in and telling me something.
Can you explain enlarged prostate? Because I hear that a lot.
Yes, yeah, we're about to talk about that. So I'm going to go in about 3 minutes, maybe less. Well, let's just go there now. So, okay, so here's a CAT scan. I don't expect you to read a CAT scan, but what you can see is here's your kidney, here's your bladder, and here's this big old thing at the opening of the bladder, okay? That big old thing is your prostate. What you can also see is this bladder has a lot of this dark area. That's fluid in your bladder. This bladder is very, very full. And you can see this dark area over here. That's actually fluid backing up all the way into the kidneys. You can see it over here as well, okay? So this is urinary. Here's another. This is the same image as I'm scrolling through the body. This is a big bladder. It's really, really full. That is urinary retention, and likely related to that big old bladder, but possibly related to diabetes. Here is enlarged prostate, one of the very common causes of urinary retention. Here is the bladder. It's thick-walled. Here's the opening of the bladder. This is the prostate. So this is the channel you pee out of, and here's the prostate. It's that big old organ that sits right at the opening of the bladder. As it grows, okay, it starts becoming nodular. And as it grows, see how this channel is nice and open? As it grows, it closes off this channel. When it runs out of space to grow outward, it starts getting pushed inward and closes off this channel. That's enlarged prostate. Enlarged prostate is a term we use for not just a big prostate per se, but a boggy prostate that's closing off the channel that you pee through. And so now your bladder is strained. It's working on overtime to try to squeeze urine past here. And when it works overtime, it can get overworked. It also is increasing the pressures in order to get the pressure inside of itself in order to push urine out. And that pressure can go backwards and then can actually hurt your kidney. So that is enlarged prostate. There are testing that we can do to check for things like enlarged prostate, but also differentiate it from things like prostate cancer. So that's PSA screening. We can check to see how well you're emptying your bladder. And there's a test called urodynamics that can actually check how well your bladder works. There are mild treatments for enlarged prostate, including medical treatments. There are minor treatments like that UroLift we talked about. It's a 5-minute procedure where we can just tack the prostate open. We can shave the inside of the prostate without ever making a cut in your body, okay? And the hope is that you can put steam in the prostate, and the hope is that by the time we're done, your channel goes from being like this to being like this, nice and wide open again, okay? So here's an example of a question that may relate to you. You're a 55-year-old male, you have diabetes, you have urgency, frequency, you wake up 3 times a night, you have strong urges and you leak if you don't make it to the restroom in time. You were prescribed Flomax, but it does not seem to help. What is your next step? What should you do? Is this normal aging? Should you see a urologist to make sure it's not your prostate? Should you just go ahead and ask someone on the streets to remove your prostate for you? Should you get checked for sleep apnea? Should you get control of your diabetes? What is the right answer?
B.
Yep, B is always a good answer. I would say the answer to every single question here today is probably see a urologist, and that would be an appropriate answer. B is a good one, but actually D and E are actually correct as well. The only 2 incorrect questions are A and C. Yeah, as you get older, you do get these symptoms more, but it's not necessarily normal A. It's just some anatomic problem that's causing it. Definitely don't have someone on the street remove your prostate till it's evaluated. So see a urologist about your bladder and prostate, yes. Make sure it's not sleep apnea if you're snoring at night, and your urologist or your primary care doctor will probably address that, because sleep apnea can actually lead to urinary symptoms. And then get better control of your diabetes, because if your diabetes is uncontrolled, those sugars are pouring into your bladder, irritating it, causing the same symptoms. But over time, the diabetes is killing your nerves and also making your bladder not function. Okay, I think this might be the last one. Stop me if I'm going too long. Low testosterone. Testosterone is important for bone health, muscle growth, hair growth, sperm production. It's also important for heart health and bone health. So these are all things that are very, very important for you. 2 in 100 men have low testosterone. So it's more common than you think. You can easily test for it just by checking early morning testosterone. And you can have signs of symptoms include fatigue, decreased bone mass, shrinking testicles, difficulty sleeping, decreased energy, decrease in sex drive, mood swings, increased body fat and decreased muscle mass, hair loss. These are all signs of low testosterone. If you have any kind of comorbidity, heart problems, diabetes, HIV, all these things, these are all risk factors for heart disease. You have a second risk factor by having low testosterone. And in fact, there is some data that shows by treating your testosterone, if you have low testosterone and diabetes, you can actually even reverse your diabetes. So there is a connection between testosterone and diabetes. The way testosterone works, let's say I was to physically give you testosterone. Well, what it does is, the way testosterone works is your brain releases FSH and LH. LH will go down and tell your testicles to produce testosterone. FSH will go down and tell your testicles to produce sperm. So it all starts on the brain, and it can be either the brain hormones or the testicular hormones that contribute to low testosterone. There are ways to treat it. I can treat it with injections, creams, pellets. There are also more natural ways to treat it, including HCG, Clomid, things that'll actually increase these FSH and LH factors to stimulate the testicle to produce more testosterone. So there are a lot of different ways to treat it. So let's say you're a 33-year-old male, you have low testosterone, you and your wife are trying to have a child, and you've been trying for several months, but you just have decreased energy and decreased sex drive. Your erections are intact. Which treatment should you avoid, and which ones should you consider? Takers. This is a hard question. So one thing I didn't mention was testosterone. If I physically give you testosterone, what will happen is your brain will say, oh, I have plenty of testosterone, and it'll actually shut down the FSH and LH, which will shut down your sperm production and shut down your testosterone production, your natural testosterone production. So in a young person, you don't want to start testosterone, especially if you're trying to have a kid, okay? Because what will happen is your ability to have a kid will slowly go down over time. And so you want to avoid C, D, and E. There are treatments that we can give you that are a little more natural. Those testosterone boosters we talked about, like HCG and Clomid, we can add instead, try to keep your testosterone higher, but in a more natural way and a way that's not going to hinder your fertility. So there are other cool things that urologists can do. And then I think this is the very, very, very last one, erectile dysfunction. Yeah, questions? Oh, okay. All right. So erectile dysfunction, how does it happen? Well, it starts with your brain. You got to have that desire to want to have sex, and that's controlled by testosterone. Stressors and anxiety can also contribute. Your nerves, so let's say your brain's intact and your testosterone's intact. Well, then when you're stimulated and aroused, your brain will tell the nerves, hey, I'm aroused, give me an erection. The nerves will release nitric oxide. So anything that can hurt nerves, diabetes, back issues, pelvic surgery, any of that can make it harder to release that nitric oxide. What that nitric oxide does is it goes to the blood vessels of the penis and swells it. And by swelling it, you can get increased blood flow into the penis and get an erection. Anything that blocks blood flow, diabetes, heart risk factor, heart disease, obesity, high blood pressure, all these things will decrease blood flow into the penis and decrease your erection. There are tests that we can do to check and see what's going on, hormone testing, nerve testing, testing for the penis itself to look at the blood flow patterns. Lifestyle changes are always a good start. Doing a heart healthy diet, keeping your diabetes in check, exercise, decreasing your stress with yoga and meditation, that's always a great start. And then there are medications that'll increase blood flow into the penis, like PDE5 inhibitors, like Viagra, Levitra, Stendra, Staxin. They're injections, they're urethral suppositories. Testosterone can help to some degree. There's vacuum erection devices, and there are surgeries. So there are an unlimited number of treatment options for erectile dysfunction. So last set of questions, you are a 66-year-old male with long-standing diabetes and erectile dysfunction. You have Viagra, you've tried Cialis, you've tried Stendra, you've tried Staxin, you've tried everything, and there's no benefit. What options should you consider? Anyone want to chime in on here?
Don't know.
Okay, well, the answer is all of them. You can try any of these. See your urologist, because he may put you on a different med. He may put you on injection therapy, or he may do a test to see if you're a candidate for that. He may start you on erections, on vacuum erection devices. He may say your testosterone's low and try to treat that. Testosterone treatment can actually improve the likelihood of the oral medications working. And then that gold standard for someone with long-standing diabetes is a penile implant. That's actually a board question, and the answer is, if the question is what is the best option for someone with long-standing diabetes is a penile implant. And the reason is because everything else is unlikely to work because of the nerve injury and all the blockages and everything that come with diabetes. So that is it. I do want to add one little note. Listen to the wives, because they're probably the smarter of the two of you. They're the ones that are going to think about you. And most men will neglect their own health, and most women are extremely good about not only taking care of themselves but taking care of their families. So we do appreciate all the wives and the moms and anybody else here that came on just for their significant other. I think that's exceptional, and I would be willing to bet, I haven't looked, but there are probably more women on here than men, primarily because women are much better about taking care of their own and their family's health. Any other questions?
Dr. Chua, this was an excellent presentation, and thank you very much.